Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. If you are hearing this right now, then you are not currently a Journal Feed subscriber, and so you will not be receiving the full Journal Feed podcast, only getting a portion of the past week's articles. If you would like to get full access to both the podcast and the blog, then you'll have to become a member. All the details for that are at journalfeed.org, and remember, we don't ever want money to be a barrier to better patient care. So if you're having any trouble affording a subscription, just get in touch and we'll help you out. This is the audio version of the past week summaries, which this week were brought to you by our authors, Nicholas Stryka, Jacob Atholtz, Samuel Rouleau, Aaron Lacey, Millie Cossé, and Clay Smith. All right, let's skip straight to the third article, titled Large Bore Mechanical Thrombectomy versus Catheter-Directed Thrombolysis and the Management of Intermediate Risk Pulmonary Embolism, the primary results of the peerless randomized control trial out of the journal Circulation. As with many conditions, the treatment of mild disease for PE is obvious. You can send these patients home on anticoagulation. As for high-risk patients, again, the management is obvious. They need thrombolysis. You need to get rid of that clot. You can even do a thrombectomy in these patients. However, for intermediate-risk patients, it's not clear exactly what needs to happen with them. That being said, the mortality of these patients is still quite significant. Trials seem to show that the mortality rates can be as high as 3 to 15%. And thus, we need to figure out exactly which patients we should be treating more aggressively, or we need to be changing our treatment in general for these patients. Now, there are two main methods which we consider to be a little bit less invasive for treating a PE than doing a full thrombolysis. And those are that you can do a thrombectomy, you can go in and take out the clot if there's an amenable clot, or you can do a catheter-directed thrombolysis. So they put a catheter into the pulmonary artery, and then they just drip lower doses of the thrombolytic agent directly over the clot. And theoretically, because you have a lower overall dose, you might have less complications. I don't know that I ever really believe this, and there's already some trials looking at whether or not we need to give the full dose of thrombolytics that we're used to giving. So it's objectionable whether or not this is all that effective, but all the same, it's definitely a legitimate strategy which is used by many people still. They were able to recruit 550 patients with acute PEs and right ventricular dysfunction on imaging and randomized them to either thrombectomy or catheter-directed thrombolysis. These were intermediate patients, with 90% of them being intermediate to high risk, so they were fairly high-risk patients in general. There was no just normal anticoagulation group in these patients because they were deemed to require some kind of treatment beyond that by the PE response team. This makes things a little bit harder to replicate in other trials, but not much to do about it. The thought that anticoagulation alone would not be enough for these patients makes it a very difficult population to isolate for other trials, which is very inconvenient because currently anticoagulation alone is the current guideline recommended therapy. So this trial should not be taken as evidence that you should be doing these more invasive procedures in the first place, but rather just as a comparison between catheter-directed thrombolysis or thrombectomy. So it's a good trial to compare those two, but it is not a good trial to justify doing any of these invasive procedures. Just keep that in mind. The primary outcome was the win ratio, which was a composite of a whole bunch of outcomes, which were all-cause mortality, intracranial hemorrhage, major bleeding, clinical deterioration or bailout therapy, and ICU admission. This was wildly positive on the side of the thrombectomy. However, most of that was driven by ICU admissions, which I'd say is not something that we care terribly much about, because for thrombectomy, you go in there, you take out the clot, and then the patient is done with their procedure. For catheter-directed thrombolysis, you leave a catheter in their pulmonary artery. This is a patient that I would be much more comfortable having in the ICU, especially if I'm dripping thrombolysis agents through that catheter. Of course, there's going to be more admission to the ICU in that group, so that's not an outcome that I'm very concerned about. However, there were lower rates of clinical deterioration in the thrombectomy group. Most of the problems with thrombectomy happened at the time of thrombectomy, whereas most of the problems with catheter-directed thrombolysis happened over the next kind of 48, 72 hours because, well, you're still dripping this thrombolytic agent into them and you still have a catheter that's there. So it's not surprising. I think this sounds pretty positive for the thrombectomy group, or it definitely sounds more like something I would want for myself. The thrombectomy group had the rates of deterioration or bailout therapy at about 2% versus about 5% for the thrombolysis group. However, altogether, there was no differences observed in mortality, intracranial hemorrhage, or major bleeding. So for me, I'd say that thrombectomy from this trial really comes out on top. They're about half as likely to get admitted to the ICU. They're much less likely to clinically deteriorate, again, less than half as likely. And all the risk is just consolidated into one briefer period. Whereas for catheter-directed thrombolysis, it kind of goes on, and they're in the ICU for this. So really, thrombectomy was looking pretty hot in this trial. Fortunately, there are also even more trials coming up. There's Peerless 2 as well as other trials which will further investigate these questions. I think our interventional radiologist colleagues are very interested to see that thrombectomy is gaining in popularity, and I've called for it a few times for my patients, and so far have had good outcomes. In a spoonful, in a trial of intermediate risk PE patients, thrombectomy outperformed catheter-directed thrombolysis. Now, don't mistake this for evidence that you should actually be doing these interventions, however, because it was not compared to the guideline recommended therapy, although it does seem to be that thrombectomy was performing better than catheter-directed thrombolysis. And then we have the fourth article titled Effectiveness of Ventilation via an Endotracheal Tube in the Pharynx versus a Face Mask in Patients with Potentially Difficult Airways. A randomized crossover and blinded trial out of the journal Anesthesiology and Analgesia. Now, of course, a can't intubate, can't oxygenate scenario is something that we're all very worried about, and the more tools that we have in our tool bag to try to combat this situation, the better. Now, one of the pillars of cannot intubate, cannot oxygenate is above just the fact that you can't intubate, you can't bag these patients either. That's the real problem, because if you can't intubate them, okay, theoretically you could just stand there and bag them for a while, but you can't do that either in these cases. The typical way to get out of this would be to place a supraglottic airway. However, it's nice to see other options. In theory, you could take that ET tube that you were ready to intubate with, and you could put it into their pharynx. These authors measured from the upper incisors to the ear canal, and they used that length to put the ET tube down just between the tongue and the palate without a laryngoscope of any kind. And now it sits right above your larynx, essentially. It's in the pharynx, and it's bypassed where you typically get obstruction, which would cause difficulty with bagging. This is very similar to having a supraglottic airway, except you don't have that nice shaping that it would have. So I don't know that this would ever be better than putting a supraglottic airway. However, in a pinch, if you haven't got anything else, then maybe it's something that you could do. These authors recruited 136 patients who were scheduled for surgery and had potentially difficult airways, as assessed by their Mallampati, their BMI, and other typical factors which go into, making us think that maybe this person's hard to intubate. What they did was a randomized crossover trial where they did 1 minute of normal mask ventilation followed by 1 minute of this tube in the pharynx ventilation. And, one started with one, the other started with the other, and then they crossed over, and they were comparing how well they were able to ventilate, looking at end-tidal CO2 levels and oxygen levels and all the sort. Of course, this was after induction. Now, the overall successful ventilation rate for the tube in the pharynx was higher than ventilation with a mask. Tube in the pharynx ventilated patients at about 94% of the time, whereas mask ventilation was only 85% of the time. Now, this mask ventilation, this sounded low, but it seems that in patients with risks for being a difficult airway, that this is about the typical number that you get even in anesthesia trials. There was no instances of the tube in the pharynx failing as a rescue maneuver after failed bag mask ventilation, although that was not necessarily true for the inverse. Now, if you want to do this method, what you do is you measure it, as I said, so from the tip of the upper incisors to the ear canal, that is how long you want to put in that ET tube. And then you just put it in blindly, and then you must make a seal with the lips around the tube and block the nares. After this, then you can ventilate as normal. In this group, they had these patients connected to the ventilators, so this might not generalize as well to the emergency department, where we're likely going to be bagging through this tube and having less consistent changes in airway pressures. For this trial, it's useful because you can get more numbers this way, however, might not generalize as well to the emergency department as we would like. The authors also maintain a jaw thrust throughout this. Something to also keep in mind is that they were not doing RSI, or they were not doing RSI doses for these patients, certainly not. They were doing half RSI dosing of rock, which means that immediately after induction, when these patients are apneic, is when they started this. However, if you're only using 0.6 milligrams per kg, then I don't expect full paralysis of my patient for the next couple of minutes, could be 3 minutes even. So these patients were likely not fully paralyzed for this trial. Another limitation is that we do not know if these patients would have just been easy to bag if I just put in a nasal or oral airway. Would that be more beneficial to get rid of that obstruction than doing this intubation method where I have to hold their nose and everything instead of doing something that I'm very familiar with, which is putting in oral airway and continuing to bag? It's not known if that would have been just as effective as just doing this ET tube method. Also, all of these patients went on to be intubated. So none of these patients were true can't intubate, can't oxygenate scenarios. So we don't know that this would apply to that population either. All in all, it's interesting. It's something cool. I like to know it, but I just don't see how this would enter into my practice. In a spoonful, this is another tool for your tool bag. You can take your ET tube and blindly put it into their pharynx and oxygenate and ventilate your patients potentially. However, I don't see when I would ever do this rather than put in a supraglottic airway or a nasal or even oral airway for that matter. Okay, that's all the articles that we have from this week. Let's do a quick review of everything we talked about. And then from the third article, to pick between thrombectomy or catheter-directed thrombolysis for intermediate level PEs, while thrombectomy seemed to come out on top. Mostly driven by rates of ICU admission, but there was also lower rates of deterioration, which is something that we definitely care about. Then from the fourth article, you can just place an ET tube in the mouth, technically in the pharynx, at a depth of the incisors to the ear canal, and this could be an effective way of ventilating your patient. Again, if you are hearing this right now, then you are not currently a part of the members feed, and so you missed 3 articles from this past week. Here's what you missed. One was an RCT looking at the best way to reduce a nursemaid's elbow. And then we looked at which medication is the most effective PO option for severe agitation in pediatric patients. And then we had a wonderful primer on occlusion myocardial infarctions. Links to all the original articles can be found at journalfeed.org. Just follow those links in your show notes. Our goal here is for you to read less, learn more, and save lives, one spoonful at a time. Thank you.